Yeah, it's that time again for the Puscast, a review of the infectious disease literature with them dare snarky commentary, don't you know? This is brought to you as always by Pusware LLC, the publisher of the Infectious Disease Compendium, a persiflager's guide, your uber hyperlink electronic guide to infectious disease, available at moremark.squarespace.com and, of course, as an iOS app. Now, this is CME accredited. When you're done, take the online quiz and get a free half an hour of CME. Thank you, as always, Legacy Health and Susan Harden. Because it is CME accredited, I must mention my potential conflicts of interests. Besides the huge sums I generate running my website, nothing. And those huge sums are relative to current Medicare reimbursement. Anyway, I must, of course, mention my growing multimedia empire over at moremark.squarespace.com, where you can find my 3 podcasts and my 2 blogs, as well as directions to my iApp. And now we'll move on to the literature. But before we do that, I just want to mention not only are there blogs and iApps and podcasts, but there's now an ebook available through Amazon.com and Lulu.com. I took the first year's essays from my Rubor, Dolor, Kalor, Tumor blog, collected them, rewrote them, expanded them, added all new typos, and have published it. $5. Such a deal. So as a Kindle app and as a iPhone app, you can read it on damn near any device you want. So now we will really move on to the literature. First up is XMRV. You might have heard of this, the xenotropic murine leukemia virus, which is a retrovirus that is been credited with being associated with chronic fatigue syndrome and prostate cancer. Unfortunately, for that hypothesis, that studies have indicated, published this month in the journal Retrovirology, that the specimens were all contaminated with XMRV in the samples. And it is probably, therefore, not a cause of either prostate cancer or chronic fatigue syndrome, which is 2 weird related illnesses from one virus. But they looked at the specimens and they compared it by all sorts of fancy schmancy molecular biology techniques and found that they were identical to specimens in the cell lines that were used in the studies. So I'm kind of bummed. I think all diseases are due to infection, genetic, or wear and tear, to quote Dr. David Gilbert. And I was most intrigued by perhaps chronic fatigue being due to a retrovirus. But in the immortal words of Queen, another one bites the dust. As we finish 2010 and head to the last year of the world, since I guess the world's supposed to end in 2012, it is time to mark the 500th anniversary of pandemic influenza. There's a fascinating viewpoint in clinical infectious disease this month that talks about the history of influenza and how shortly after Columbus discovered the New World, that influenza had its first pandemic, sweeping virtually the entire world except for the New World back in the year 1510. There had been reports of a coughing illness that sounds like flu reported for at least 650 years prior to this pandemic, but the first pandemic was indeed in 1510 as best we can tell, probably because that was a time when they had enough transportation and trade to spread flu along trade routes. They called it the, I love this term, gasping oppression, with cough, fever, and a sensation of constriction of the heart and lungs, and it appeared everywhere all at once in 1510. The other thing the 1510 pandemic had in common with the current pandemic is that it had a high attack rate and relatively low mortality. So I'm taping this. Well, I'm not taping this, how old I am. I'm recording this on New Year's Eve day, and tonight, raise a glass of champagne and toast the 500th anniversary of pandemic influenza. Woot. There were 4 articles in Clinical Infectious Diseases in the December 15th issue, and I'm going to talk about all of them as a group, and if you want, you can just go to the December 15th Clinical Infectious Diseases for the specific reference. So the first concerned the immunogenicity of the H1N1 vaccine in children with cancer, and they found that this vaccine for H1N1 did induce limited but protective immune responses in children with cancer. Obviously a high-risk group for death and a low-risk group for responding to the vaccine, and overall about 44% of the kids with cancer, including kids with leukemias, responded to the vaccine with what should be a protective rise in the antibody titer directed against H1N1. The next study looked at the results in kids with getting pandemic H1N1 if they got the seasonal H1N1 vaccine. So they had a bunch of kids who had 1 dose of the trivalent seasonal vaccine in November of 2008 versus a placebo. They found that those who had the vaccine had less seasonal influenza, H1N1, 21% of the placebo group and 8% of the vaccine group got seasonal influenza. How did this protect against pandemic H1N1, the so-called swine flu? Well, it turned out that if you got a case of H1N1, the seasonal version, you were protected against getting the pandemic strain, probably because of cross-reaction to other epitopes. And the receipt of the seasonal H1N1 did not increase the risk of H1N1 pandemic, which has been suggested in some studies. In the raw data, receipt of the seasonal vaccine actually increased the rates of pandemic H1N1, but in multivariate analysis, that result did not hold true. It's interesting that flu mortality is not the same everywhere. Another study in this same Clinical Infectious Diseases looked at the influenza-related excess mortality and compared South African elderly patients to U.S. patients. In South Africa, there were 545 deaths per 100,000 versus 133 deaths per 100,000 for all causes, and 63 per 100,000 in Africa versus 21 per 100,000 in the United States for mortality. They suggest this may be due to socioeconomic differences as well as perhaps co-circulation of other infectious diseases in South Africa. Pregnant women, but not pregnant men, tend to be little wiggins about getting a flu vaccine, even though pregnant women are the ones who are most likely to die from flu. But also, giving the vaccine protects the children. This study looked at the difference of hospitalization due to influenza in women who had the vaccine whilst pregnant. 2% of those who got the vaccine were admitted for flu versus 19.9% of the cases who were admitted to flu. So if you get the flu vaccine while pregnant, not only will you protect yourself, but you will protect your newborn. It's all for the children. I have noticed that people appear to like to have sex, and they appear to like to have it frequently. Because of this, they're at risk for various and sundry diseases like HIV. And preventative measures have not been that great in preventing HIV. In this study, they looked at almost 2,500 HIV seronegative men or transgender women who have sex with men, and they either got placebo or they got emtricitabine and tenofovir once a day for prophylaxis. And they found that those who had the preventative medications had less HIV acquisition. Of the 100 patients in the cohort who developed HIV, There were 36 in the treatment group and 64 in the placebo group, giving a 44% reduction in the incidence of HIV if you took prophylactic medications. And in looking at the trial, patients were not particularly adherent with their compliance or compliant with their adherence with the medications, missing about 10% of the medication doses. And it should be emphasized that this study was done in conjunction with education about other measures to prevent HIV. But still, people like to have sex, and they like to have unprotected sex. How this can be implemented in the real world with the cost of the medications, the toxicities of the medications, and the fact that it will probably help breed resistance of HIV is problematic. But it is at least proof of concept that chemoprophylaxis does work for HIV. There is a family of viruses called the parapox viruses. The most famous, or at least well known to me, is the ORF virus, which became a character in a TV show, I think. He was kind of a puppet from another planet. Anyway, you get the ORF virus from handling sheep, and you get this skin nodule that looks like it's a boil, but is actually a solid mass of histiocytes. Now, there's another parapox virus that was described in the Northeast that deer hunters acquired. And there were 2 case reports of people who were hunting deer in the Northeast, and they did what's called field dressed the deer. I suppose that's where you go have it put on pants and a vest. Anyway, 2 people came down with lesions on their hands that were similar to a ORF lesion, but turned out to be the parapox virus from deer. There are, FYI, other parapoxes out there besides ORF, and it depends on the animal. So you can get ORF from sheep and goats, and you can get bovine papular stomatitis and pseudo-cowpox virus in cattle. And there are also others in other ruminants. There's a seal pox, and there's a parapox in the deer in Japan, New Zealand, and Northern European reindeer. These are all very rare. But still, if you're going to go out and kill Bambi for dinner, don't forget you might get the parapox virus. Bambi. One of my favorite shows of all time was the PBS show Connections. I love the way they would take some event in the distant past and show how through a series of connections it led to some event that's occurring currently. Usually these are inventions of some type. Now, there's always a problem with new invasive plants and shrubs. They can have unintended consequences. And there's a specific invasive shrub in North America called the armor honeysuckle. What happens is as follows. You get overgrowth of honeysuckle. The honeysuckle is the preferred chow down of the deer. So where you have lots of honeysuckle, you have lots of deer. With the deer comes, ticks. And you find more ticks in areas that have more deer that have more honeysuckle. And what does the tick carry? That's right, ehrlichiosis. So increases in ehrlichiosis are due to more ticks, which is due to more deer, which is due to more invasive honeysuckle. I love the way all these things are related. So if you want to control ehrlichiosis, get rid of the honeysuckle. Much of supplement, complementary, and alternative medicine, that acronym is SCAMS, comes about either by divine revelation or fiat. People decide that something works, based on no experience and no data. That's true of echinacea. Historically, it was used by Native Americans for a wide variety of medical problems. And somewhere along the line last century, somebody decided it worked for colds. There have been multiple studies to show that echinacea does nothing for colds. It neither treats colds nor prevents colds. And, probably more importantly, there's no reason to suggest that it should. Now, the Annals of Internal Medicine published a randomized trial for echinacea for treating the common cold. They had a little over 700 patients who were randomized to placebo or echinacea and found that echinacea did nothing. Quelle surprise. It is an interesting study because they had 4 wings in the treatment groups. They had no treatment, they had placebo, they had randomized blinded echinacea, and they had echinacea and they knew they were getting it. Now they determined duration of illness not from the onset of the illness, but from the onset of enrollment into the study. And then they were asked twice a day, do you think you have a cold? And they answered yes or no. And if they said no, then they marked that as the end point of the duration. You can instantly see the problem there as to how long cold lasts because A, you don't know how long they were sick prior to the onset of therapy, and twice a day sort of misses when you may not have a cold, as if anybody's cold ends at a precise time. I mean, this is kind of stupid, is that viral illnesses sort of dribble off the court rather than getting universally better. So you can say you're better, but that would also be dependent upon how much of a manly man you were to determine whether or not you had a cold. In the end, there was no difference through the groups, although they suggest that there was a half-a-day difference between the echinacea and the no treatment group. Given the methodologic problems with determining duration of illness, I don't think that is a reasonable conclusion from the study. However, as they say at the end, individual choices about whether to use echinacea to treat the common cold should be guided by personal health values and preferences, as well as by the limited evidence available. Well, the limited evidence available pretty much suggests that the best studies showed no efficacy of echinacea, so I don't think that a physician should be personally recommending things that don't work on the basis of patient personal preference. I mean, if they wanted internal mammary ligations, which have been shown to be no better than placebo for treating angina, but it was the patient's personal preference, would you recommend it? I just find this kind of weasel stuff, as you can tell, annoying at no end, and will probably rant at length on it in my next Quackcast. Bottom line, there is no good data to suggest echinacea should work. I think of C. difficile more as an overgrowth environmental problem than I do an infection in the classic sense of the word. You wipe out the normal flora, C. diff overgrows. But what is the important normal flora that is altered in patients with C. difficile? I mean, you cannot grow probably 97% of the organisms in the GI tract. So this study looked at patients admitted to the hospital, 600 of them in fact, and they got stool samples within admission and then watched to see how their stool changed if they developed C. difficile or not. Rather than cultures, they used the 16S ribosome RNA microarray, which can identify boku organisms without ever having the need to grow them. And they found associations between alterations in the gastrointestinal tract flora and subsequent C. difficile, although they did not find across the board a diminution in bacterial flora. Interestingly, the two medications that had the most effect on the bowel flora were quinolones, no surprise there, but also NSAIDs. They found that by using probe intensities, and I'm going to pronounce these bacteria wrong, that if you had higher amounts of Firmicutes, which sounds like a workout tape, proteobacteria, actinobacteria, you had increased association with C. diff. I want to say association is not causation. And they also had decrease in the Bacteroides family of bacteria. So a relative change in the proportion of bacteria in patients who develop C. diff, either from NSAIDs or quinolones, interestingly, was associated with developing Clostridium difficile diarrhea. Of course, there's all these statistical analyses that my brain is too puny to understand, but also, quote, after adjustment for covariates, we did observe an association between high probe intensities for, ironically enough, lactobacilli and enterococci among patients with C. difficile colitis. So, interestingly, people with C. diff are more likely to have lots of lactobacillus in their stool, which kind of makes you wonder about the point of probiotics. But of course, I don't treat C. diff with probiotics. And curiously, the data suggests that it is a good preventative, so I don't know where to go with that. There is a subgroup of people who think that raw milk is better for you than pasteurized milk. Louis Pasteur, of course, has probably saved more lives with his discovery or invention of pasteurization than probably any other individual in infectious disease history. However, people insist upon drinking raw cow's milk, and they get infections as a result. This was a report of an outbreak of E. coli 0157 with resultant hemolytic uremic syndrome requiring 21% of the patients in the outbreak to be hospitalized. And they traced it back to raw milk consumption from a cow that had E. coli OH157. The interesting thing about raw milk drinkers, according to this article, is that 1 to 3% of the U.S. population are estimated to take or consume raw milk, but it's responsible for 70% of the dairy outbreaks of infectious diseases. One of the ways, by the way, that people get around illegal selling of raw milk is they timeshare a cow. So if you own or partly own a cow, you can do anything with it what you want. Well, within reason. And including in that is drinking the milk straight from the cow, which I think defines stupid in my book. But here in the Northwest, time-sharing a cow is how people get around the laws against selling and buying raw milk. An interesting thing about gastroenteritis is that the sequela can be long-term. There's been a bunch of articles we've talked about on this podcast about how getting travelers diarrhea is associated with long-term irritable bowel syndrome, as is getting other infectious diseases causing long-term irritable bowel syndrome, or at least associated with it. Don't know causation for a fact. The British Medical Journal published an article where they looked at an outbreak of E. coli OH157 and followed them long term. They had 1,977 patients in this study. There was a huge outbreak, evidently in a Canadian water supply, got contaminated and caused E. coli OH157 outbreak. It turned out that patients who drank that and had water contaminated with either E. coli or Campylobacter had an increased risk long term of self-reported hypertension, renal impairment, and cardiovascular disease. Now, that may be a fluke, as often happens in epidemiologic studies, but getting infections can have long-term consequences. Just tell your significant other that you had gonorrhea and see what happens. Okay, there's some things that I just don't understand, and I'm hopeful that somebody in my listening audience will explain this to me. This article in the Clinical Infectious Diseases compared ceftriaxone to ceftaroline in patients with community-acquired pneumonia. They had more or less the same success rates. For clinical cure, the ceftriaxone group was 77.7%, and for the ceftaroline group, 84% got clinical cure. 2% of patients died in each wing. So, what happened to the other 15 or so percent that were neither cured nor died? I never quite understand that in these studies. Do they drift along in some suspended animation? Are they still in the hospital coughing up sputum and febrile? Did they get changed to antibiotics? Or is this just a function of the endpoint and that in the end everybody got better? I mean, in the end with pneumonia, you got two options. You get cured or you die. There is nothing in between. So I don't understand these types of studies, except that, here's my bias, they always spin it so that the agent, in this case the ceftaroline, which is the one that is sponsored by the company, looks better somehow than the comparator agent. For all practical intents and purposes, my reading of the study says for community-acquired pneumonia, they're identical. So, you know my motto. You can kiss my aspergillosis. Now, I have never seen, I think, a case of chronic pulmonary aspergillosis, now that I think about it. But what would the optimal therapy for that disease be in this day and age? Certainly, posaconazole and voriconazole have much better efficacy against aspergillus than does the other azole antibiotics. This study looked at the use of posaconazole, 400 milligrams twice a day, and found good efficacy in the treatment of chronic pulmonary aspergillosis. They had 4 failures, all of which had resistant aspergillus. So take-home message is always, if you treat an infection with an antibiotic to which the organism is resistant, you can pretty much be assured that your outcome is going to be, shall we say, suboptimal. The interesting thing about this study is how long it took some patients to respond. There were patients who didn't respond until they were on a year of therapy, which is pretty remarkable duration to wait for patients to improve, especially given the cost of posaconazole, which currently runs about firstborn male child plus a kidney. Still, Posa and Vori are very important antibiotics in our antifungal armamentariums. It's time now for the hodgepodge. There will be no references, but that's why God gave us Google. This study looked at pagers and stethoscopes and carriage of bacteria. And they found that 25% of pagers and 27% of stethoscopes were contaminated, primarily with enterococci. Quit putting those where the sun don't shine, staphylococci and enterobacteriaceae. I'm now in the habit of foaming my stethoscope at the same time I foam my hands. I wonder if I should foam my pager as well. Artesunate, a treatment for malaria, causes dose-dependent neutropenia, so something to look for in treating malaria. Also, the big problem of infections in the third world is that it makes kids stupid. Kids with chronic infections don't perform as well. Kids with a history of infections do not perform as well in school. And this study looked at cognitive impairment in kids who either had uncomplicated or cerebral malaria and found that kids who got malaria had decrease in cognitive abilities in school performance. Infections really do bad things to the people of the third world besides acutely killing them. Whipworm. If you were to ask Devo, he'd say, how would you whip it good? What is the best therapy for the treatment of whipworm? This study, which was done in Zanzibar, looked at ivermectin added to albendazole and mebendazole and found that the combination was superior to monotherapy in the treatment of kids with whipworm. Just remember that there's a different cryptococcus, we've talked about this before, in Vietnam, Cryptococcus neoformans variety grubii, and accounts for most of the cryptococcus in both AIDS and non-AIDS patients in Vietnam. The PCR for invasive candidiasis appears to be a good test with good sensitivity, 95%, and good specificity, 92%. And compared to patients with known positive blood cultures to normal people, the sensitivity and specificity of the Candida PCR is actually 100%. The study, which was published in the Journal of Neurologic Science, looked at the use of aspirin with tuberculous meningitis and found that patients who took aspirin while they did not have a decrease in stroke did have a decrease in mortality. They received 150 milligrams of aspirin a day, and corticosteroids did not appear to have any effect combined with the aspirin on mortality and stroke. So it was effect of the aspirin alone. Truly the wonder drug that works wonders. Yet another study, this one out of South Africa, that shows taking quinolones for community-acquired pneumonia in an area of high endemicity for tuberculosis delays the diagnosis of tuberculosis because the patients get treated and they're better. But it's not because of bacterial process, it's because they actually responded to tuberculosis. Nocardia resistance is increasing. This study was a 10-year retrospective look at nocardia and found that 61% were resistant to sulfamethoxazole and 42% were resistant to TMP sulfa, the most common strains being Nova basiliensis and Furcicina. I think the take-home message, though, is if you have a nocardia infection, the patient needs susceptibility testing done, and you cannot rely upon these organisms to be susceptible to sulfa drugs. This is a retrospective study that looked at vancomycin versus clindamycin in the inpatient setting for cellulitis, and they had very little clindamycin resistance, and all the patients did peachy keen regardless of which agent they were on. We have a lot of clindamycin resistance in the Northwest, so I am hesitant to use it if I do not have susceptibilities. Good news for all you infectious disease doctors out there. Travelers to Haiti are bringing cholera? That's what you get when you have cholera and diarrhea. You get cholera. They're bringing cholera to the United States. Yippee and skippy. As long as you're traveling, besides cholera, don't forget about anal warts. If you're traveling to Germany, the incidence there is about 169 per 100,000 person years. So be careful in Germany, as well as in China, where syphilis is taking off. And be very careful. You're going to Guangdong province, especially in the Pearl River Delta region, which has 44% of the syphilis cases. Syphilis has gone from a rate of 0.88 per 100,000 to 7.61 per 100,000 between 1995 and 2008. When patients are infected with hepatitis C, they are often co-infected with multiple viral subtypes. That was an article in CID. And women who are healthy with CMV can excrete CMV for prolonged periods of time. That may be important in determining safety of a woman getting pregnant while she has CMV, because, of course, you want to avoid congenital CMV. But they're trying to work out exactly when babies are at risk for CMV. It's long been thought that it was having acute infection that put the baby at risk. But if the female excretes CMV, or you can find it in her blood for long periods of time, is the baby at risk? Unknown. They need to do more research. So we're at the end of another Puscast. I always try and make this 30 minutes. This one covered the last 2 weeks of December 2010. I'm recording this on New Year's Day 2011, 1/1/11. Happy New Year. Now that you've listened to this, take the online quiz and get some free CME, half an hour's worth, just for listening to me babble away and answering a couple simple questions. This is brought to you, of course, by Pusware LLC, publisher of the Infectious Disease Compendium, a persiflager's guide, available at pusware.com, where you can find links to my growing multimedia empire. My count them three podcasts. The Quackcast won Best Podcast again. I am amazing. My 2 blogs, Rubodor Larcalo Tumor and Science-Based Medicine, where I participate. My iPhone app, and now, as I mentioned at the beginning, the Pus Whisperer, A Year in the Life of an Infectious Disease Doctor, available on Amazon.com and Lulu.com as an ebook for a paltry $5. In fact, you can support this podcast by going and buying the book and telling other people to go and buy the book. Otherwise, this is copyright 2010 and 2011 under the Creative Commons license. The music is by my son, when improvising on the guitar when he was 12. He's 17 now. Boy, I've been doing this for a long time. And finally, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. We'll continue to follow along with you. Thank you. In dictation, and Happy New Year.